بسم الله الرحمن بسم الله الرحمن الرحيم، والصلاة والسلام على أفضل المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أهلا بالجميع. Welcome everybody in your society very active program. Tonight we have a very interesting and very important topic in Zoster vaccine in CKD and post-transplant patients. Our sponsoring company were kindly supported this program, and they are always with us. Our GCK, which we thank them from the deepest of our heart. Tonight, our moderator is Dr. Reem Al-Amir. She's a graduate of King Saud University 2012 with honor degree. Then she obtained the Saudi Board of Internal Medicine 2017. Later on, she pursued her education and she got the American Board of Internal Medicine from Virginia University. Later on, she got the American Board and or fellowship from Pittsburgh and infectious disease, and finally she get the American Board of Infectious Disease November 22, 2022, and she managed to get a very close approach. Although when she was a student, I used to encourage her to be a nephrologist, but at least now she's very close to us. She get transplant infection disease fellowship from University of Pittsburgh. I really happy to be introducing her tonight, and I think we have, without any further delay, after thanking GCK and Even True for the always support, please, Dr. Reem, take the floor.
Thank you so much, Prof. I'm really glad I'm here. Thank you so much to the Saudi Society of Nephrology and Transplantation for hosting. This is a very amazing webinar. This is one of the dearest topics to my heart, preventive medicine in general and specifically vaccination. I'm just going to go over the flow of tonight. So initially, we'll have Dr. Reem Maghribi presenting her lecture about Zoster vaccine. Then I'll give you a few slides about incorporating Shingrix vaccine into our clinical practice, and then we'll end with questions from the audience. So please feel free to type your questions in the question and answer box down below. I'm going to be very biased. Dr. Reem Al-Maghribi is my mentor. She continues to be my mentor. Dr. Reem Al-Maghribi is a consultant and section head of transplant infectious diseases from the Organ Transplant Center in King Faisal. She did her residency in King Faisal Hospital in Riyadh, and then she was appointed as a chief resident. She pursued her training in the States. You will hear a very similar pathway as I did, because she was obviously my mentor. So initially, she obtained her American Board of Internal Medicine, then followed by American Board of Infectious Diseases. She did a subspecialty in transplant infectious diseases. She have a great interest in research, specifically advanced diagnostics and gram-negative resistance, and many more. So without further ado, Dr. Reem today will talk to us about Zoster vaccine and chronic kidney disease and post-renal transplant. Go ahead, Dr. Reem.
Thank you very much, Dr. Al-Amir, for the kind introduction. And I would like also to thank the Society for the invitation and the organizers for making everything very easy for us tonight. So inshallah, over the next 30 minutes or so, I'm going to talk about Zoster vaccine in CKD and post-renal transplant patients. Before that, I'll just touch briefly on the what is varicella zoster virus, what is the epidemiology, hint on what is the effect of zoster on the general population, but with the specifics on patients with renal disease. What complications do we expect in patients who had varicella or zoster? And what are the strategies for prevention? That is here tonight. I'll just focus on the vaccinations. And how do we expect these vaccines to work? And only one slide about treatment. So in general, varicella zoster is one of the double-stranded DNA viruses. It's an alpha herpes virus that naturally infects only humans, so there is no animal reservoir. Its main target are T lymphocytes, epithelial cells, and ganglia, as we are going to also share with you later. The primary infection called chickenpox, but then it actually becomes a latent virus and remain in the in the ganglionic neurons, waiting for an opportunity for reactivation where shingles or herpes zoster occurs. And it's a very highly communicable disease, especially for the population of interest tonight, the end-stage kidney disease patient and renal transplant. And more transmission actually happens in temperate climate. So this table, just to show you the differences in the epidemiology, and this is based on seroprevalence studies between the temperate climate, which is highlighted in the blue box in the above, and then the tropical and the subtropical countries, which is highlighted in the red box in the second half of the table. And here are the numbers that delineate the seroprevalence in those countries. So if you look into the Western Europe, United States, or other temperate climate countries, you will see that we are talking about a seroprevalence of 85% and above. But if you look into the tropical and the subtropical areas where Saudi Arabia and the other countries in the Gulf is located, you will see a difference in the seroprevalence between, well, let's say about 30% up to 98% in some countries. But I just want to also just remind everybody that the seroprevalence study does not really give a very good estimation of the, especially in the tropical and the subtropical areas, because it really depends on the publication, how did these seroprevalence studies done. So it really has some publication bias. At the bottom of the slide, you will see the United Arab, so which is around 81%. And it is has been cited, at least in this paper, to be similar rates in Saudi Arabia. So we're talking about 80% to 85% seroprevalence or seropositivity in the Saudi population. So what happens after a patient gets varicella, as I mentioned earlier in the previous slide, and I'm also going to touch on that again in later slides, is anybody who developed or had varicella in the past is virtually at risk for herpes zoster. And this risk usually increases with age, and it has been estimated and published in the CDC website that approximately 1 in 3 people in the United States will develop herpes zoster during their lifetime. The other patient population who are at risk, other than the patients or population more than 50 years of age, are the immunocompromised patients, especially bone marrow transplant or solid organ transplant recipients, patients who are receiving chemotherapy, but especially leukemia and lymphoma, owing to the highest number or the highest toxicity that occurs with the chemotherapy given for these conditions. Herpes immunodeficiency virus, especially when those patients are not controlled either virologically or immunologically, and patients who are immunosuppressive medication for indication other than organ transplantation or bone marrow transplantation, so autoimmune disease, or if the patient is also having any sort of primary immune deficiencies, those patients are definitely at higher risk for zoster infection. So what about varicella? And when I say varicella, and during the presentation, I mainly refer to the chickenpox part. So varicella infections in patients with end-stage renal disease. This was a systematic review that looked into the seroprevalence and also to the impact of the disease on those special population if it is reported in the particular studies. So when it comes to the seroprevalence, 4 out of 7 studies evaluated the seronegativity among patients with end-stage renal disease and found that 40% to 100% of those patients had no prior immunity, so they don't have protective antibodies. And 3 out of 7 studies that evaluated the seronegativity among different populations along the spectrum of CKD found that patients renal transplant ranging between 2 and 100%, candidates for transplantation around only 9.8% being seronegative, and hemodialysis patient around 2.1. What is the impact of the disease? And among the studies that were looked at in this systematic review, 19 study looked into the mortality reported 19 patients reported mortality, and the major causes of mortality, we believe it was related somehow to the varicella, was fulminant liver failure, encephalitis, that had led to DIC, or patients also presenting with pneumonia and ended up with multi-organ failure. Other than mortality, which is something I think is very important to all physicians, especially now in the current climate, is the length of stay and the cost of hospitalization. So we're talking about between 2 to 40 days. And the majority of those were due to complications that particularly, or at least in this systematic review, was thought to be related to the varicella infection. What about Zoster? Again, there was a few systematic reviews that looked into the effect of Zoster on patients with renal disease. So there, for example, here a study from Taiwan looked into around 800 patients who are just beginning dialysis and matched them to patients who are not, or who did not have an end-stage kidney disease, but matched them based on age and sex, and found that the incidence of herpes zoster was significantly higher in the hemodialysis cohort, was in this case was 73.3 events per 1,000 person year compared to 31. So we're talking about almost doubling the incidence in patients with end-stage kidney disease on dialysis. And when they also did the adjustment for confounder, the hemodialysis per se was still an independent risk factor for development of herpes zoster. Another or a similar study from China, but this was a case control study where they actually matched cases with herpes zoster to controls who did not have herpes zoster, again, trying to find what are the risk factors for herpes zoster and CKD patients. And again, you can see that hemodialysis came up as a major risk factor for development of herpes zoster, and also patients on immunosuppressant medication for different indication, which probably had led, or any indication that had led to development of end-stage kidney disease. This is another systematic review or a study that looked into the herpes zoster incidence along the spectrum of chronic kidney disease, whether it's just a chronic kidney disease or dialysis or transplantation. So on the right-hand side, you will see the odds ratio and then the confidence interval along the spectrum. So in renal transplant patient, we're talking about 8.5%, or say 8.5 more likely to develop herpes zoster in those patients. Peritoneal dialysis 3.61, and in hemodialysis 1.3. And if you see the numbers of the patients included, you can see that there was a very good number, especially when we're talking about CKD patients not on dialysis. But again, patients on dialysis were around 4,000 patients. So I think this study is really representative of the impact of this disease on the end-stage kidney disease patients. Moving on to how does this virus present? As I mentioned earlier, so there are two main phases of varicella infection in human. The first one, which usually happens during childhood or early adolescence, especially in the tropical and subtropical areas. Usually it happens in early adolescence. So you can see here that this is a varicella or chickenpox, where you see mostly diffuse rash. It's very rarely that we see complication, but complication has been reported in pediatric age group, and you can see it here listed. But then the virus goes into a period of latency, where it establishes latency in the ganglionic neurons. And then whenever there is any decrease in the immunity, and the classical example of this, as we are talking about it tonight, is, for example, organ transplantation. Patient may develop reactivation, and this is what we call zoster. Again, zoster, as I mentioned earlier, can happen in patients or in population more than 50 years of age. But one of the other differences in not only the presentation, or as you can see here, the diffuse rash compared with dermatomal or multidermatomal rash, we also could see some diffuse zoster in patients with end-stage kidney disease or transplant patients. The second thing is the complication, very rare in the childhood, but more common to see the complication in the adulthood, where you can see zoster. But it's very important to know that post-herpetic neuralgia is actually one of the most important complications that could happen after zoster, and it's really debilitating and requires sometimes multiple lines of medication to control it. So if we look into the complications, most of the complications related to zoster specifically are related to the central nervous system, which I think is understandable after seeing where does this virus reside after the initial infection. So the zoster paresis is most of the time is reported as transient, But at least in this publication was thought that around 50% of those patients may have some remaining weakness after the first 3 months from the infection. So they could have an arm or leg weakness after cervical or lumbar zoster. And the prognosis, as I mentioned, varies, but 50% may recover. Post-herpetic neuralgia, as I mentioned earlier, is one of the most common and debilitating complications of zoster, and it's defined as pain that persists 3 months after the onset of rash. And in the bottom of the slide, you could see the risk factors, which is more or less similar to the risk factor why would patient develop zoster. But it's very important to see patients who are severely immunosuppressed, and some of our patients in the transplant population are more immunosuppressed than others. So those patients are more likely to develop complication compared with other patients. Meningitis or meningoencephalitis, one very important thing to mention here, that meningitis could actually happen related to zoster without an evidence of rash. And usually we diagnose that based on the molecular testing and the presence of the VZV PCR positive from the CSF. Other CNS complication could happen myelitis, large vessel granulomatous arthritis, or small vessel encephalitis, which could also have some other complication like I'm going to mention in the next slide. So VZV vasculopathy is also one of the very important that I really wanted to highlight here, that around 30% of adult patients who developed zoster, their risk for development of stroke within the first 1 year after the zoster reaches up to 30%, which is a very significant number if we look into the larger population of end-stage kidney disease patients on dialysis here in the kingdom, but also the renal transplant patient. Usually presents with headache, mental status changes, focal neurological deficit. It can involve both large and small vessels. MRI usually is the diagnostic modality of choice. Again, this is a disease or a complication that may happen without the evidence of rash. So this patient may just present with pain and later on present with vasculopathy. The CSF may or may not be positive. It depends on the presence of meningeal involvement. More recently, I would talk about the last 5 to 7 years. There has been increasing reports with the linking the VZV reactivation with the giant cell arthritis. And here in this very nice review that I think I really invite everybody to read it. Yes, it's around 9-year-old, but I think it really delineates the complication related to VZV very, very nicely. So they had reported that in a study where they did biopsies from the temporal arteries, actually the VZV antigen was positive, and that's why it was thought that maybe VZV has a role in the development of giant cell arthritis. Eye complication is also one of the other very important complications, especially if you see in the first box on the left-hand side that some of these complications may actually lead to blindness. For example, acute retinal necrosis, progressive retinal necrosis, especially in immunocompromised patients. They also may present with retinal hemorrhages, and it can be very difficult to diagnose in the absence of rash or in the absence of any other manifestation that would support the diagnosis of VZV. But most of the time, the ophthalmologist will know how, especially when they see the acute retinal necrosis, most of the time they will be able to say, at least clinically, that this is consistent with varicella infection. As I mentioned, aseptic meningitis or vasculitis, usually the patients with neurological disease, the VZV ocular disorder can occur even, as I mentioned, without a rash. So how do we prevent it? And as I mentioned, I'm going only to focus on the vaccination as prevention strategy. So we start with the varicella vaccination to prevent chickenpox. This was actually discovered in Japan way before, so in the 70s, and was very attractive to the population in the United States, especially that around that time, a lot of patients or a lot of children with leukemias had died because of varicella or chickenpox infection. So it went through rigorous evaluation in the United States, but eventually got approved in 1995. And at that time, it was licensed as one dose vaccination at around 1 year of age. But then in 2007, the second dose was implemented because it has been shown to offer greater protection than the one dose regimen. And the CDC, the US CDC had its specific recommendation on the scheduling of the second dose of the vaccine. Did the varicella vaccine reduce the incidence of chickenpox in the United States? Very much so. And you can see in the upper half of the slide, two regions from the United States, Philadelphia and Antelope Valley, where you can see clearly the line where the incidence of varicella has dropped significantly. But not only that, but also the average mortality related to varicella in another study has declined by 88%. And the decline happened in all age group, so in all pediatric age group, but it was more so in the younger, among the children and younger adolescents compared with the adult population. I did not really find a local study here from Saudi Arabia, but this was a study recently published detailing the Qatar experience and after the introduction of the varicella vaccine. So you can see on the y-axis the vaccination status, and then on the x-axis how many doses of the vaccine were given. And then the columns delineate the cases versus the control, where cases are in blue and the controls are in orange. And without me explaining a lot, you could see the effect of the vaccination. So patients who received 2 doses had a very low incidence of development of varicella vaccine. And then the 1 dose, and then when you compare that with a patient who did not develop, who did not have any single dose of vaccination. So it's clearly delineated either from the studies from the United States or from regional studies like the one from Qatar, that varicella vaccination has been shown to be protective for children in different age group, but more importantly, the study from the United States that showed decrease in mortality as well. There has been a lot of studies looking into the exogenous or endogenous stimulation for the varicella vaccine and whether that does anything to the protection from the previous or the original varicella vaccine that was given during childhood. So for example, if a child had a varicella vaccine, but then because the vaccine may wane after around 10 years or so, so by age 6 or 7 or 8, if this child had been exposed to varicella, so a patient with varicella, this actually may increase the antibodies again and boost the immunity. And this is called exogenous effect or exogenous boosting of the immune response. So studies has been done to show what if we give another vaccination, and this is called, because they are using a different strain of the virus. So what if we use another vaccination, whether that will also boost the prior immunization, and that had actually been proven to be correct. And this was one of the bases of introducing zoster vaccines later after the initial vaccination has waned, or for population who were not vaccinated before. So this is one of the first vaccines for zoster that came to market. The live attenuated vaccine was introduced in the mid-2000s, and in the phase 3 study, the live vaccine did reduce the burden of varicella among immunocompetent population above the age of 60 by around 61%. Very important, another endpoint, which is the reduction in the incidence of post-herpetic neuralgia, and also the incidence of reactivation of varicella by 51%. So that was very useful endpoint, and it showed that this vaccine may also have a very important role in the adult population. Because it's a live attenuated vaccine, so it was contraindicated in immunocompromised individual, although there has been some work after that, especially with patients on stable immunosuppressive medication. But then the more post-marketing studies also showed that, as I mentioned, also with the varicella vaccine, that the protection may wane over time. And most of the studies mentioned that around a decade where you would see the waning of the protection from the live attenuated varicella or zoster vaccine. And then the recombinant vaccine came later, and there has been multiple phase 3 clinical trial that looked into the recombinant vaccine immunogenicity in different populations, so 50 years of age and above immunocompetent again, age of 70 years and above. And you can see here the results of these clinical trials. So it did show 96% above 50, 97% above 60, and 91% above 70. So we're talking about a very good protection rate against zoster in the most vulnerable population, which is the age more than 50. It also showed a reduction of around 88%, again, in one of the very important endpoint, which is the post-herpetic neuralgia. And it did, the vaccination schedule consists of 2 intramuscular injections to be given 2 months apart, or at most within 6 months from the first dose. This is a systematic review and meta-analysis that looked into the effect of the zoster vaccinations in general on different patient populations, or the recombinant vaccine on the different patient populations. So you will see in the first half of these forest blot, the immunocompetent, and then the second half, the immunocompromised. Again, in the first row, you will see the results of the RCT, but then the second row will be the observational studies. And without going into too much detail, the forest blot shows clearly that in either immunocompetent or immunocompromised, whether it's an RCT or observational study, it did show a consistent result of protection against herpes zoster, and you could see the risk ratio very much decreased with the vaccination in different patient population and different age group. Again, I think I mentioned briefly, or I mentioned multiple times, the effect of the complication of the zoster, and it is not only the herpes zoster in its own, but it's also the complication that we are trying to prevent or reduce the incidence for by doing the vaccination. Again, this is from the same meta-analysis and systematic reviews, looked into the complication, which patient population are we talking about, and then you will see the percentage per person year, the certainty of the grade of the recommendation, or the strength of the observation, the relative risk, and the anticipated absolute effect. And I really don't want to take much of your time, and I just highlighted here the immunocompromised population. But you could see that if you look into the third or the last column on the right-hand side, you could see that there are definitely fewer cases had complication in the immunocompromised, and we're talking about CNS complication, post-herpetic neuralgia, or ophthalmicus, as you can see here, but also hospitalization, although hospitalization was not as strong as the others, probably because most of those patients will require IV therapy, and that's why they get hospitalized. But at least here we see clearly the effect of the vaccination on the complication. The cost of the vaccine and whether that is cost effective or not is something that physicians always talk about. And I was really happy to see this study that looked into the cost effectiveness of the herpes zoster vaccine in the United States. They looked into different parameters to show the impact of the vaccination. And one of the most important parameters is the QALY, which is the quality of life gained from an intervention. And you could see here that the quality of life gained because of the herpes zoster vaccination did actually cost money. So even if the vaccine is more expensive than the other types of prevention strategies, it is definitely worth the cost, and it is definitely more cost effective. And I hope that was made clear because of the decrease in the rate of hospitalization and the rate of complication that will require multiple visits to the healthcare system. One of the other also very important things that when we talk about vaccination, patients with end-stage kidney disease or post-transplant patients, it's really very well known that end-stage renal disease patient may not respond to vaccination as well as the other or the immunocompetent patient. And there has been many efforts, for example, in hepatitis B or influenza, to double the dose, give shortened or more focused series of vaccination to induce the immunogenicity. Same thing definitely has been studied in the varicella zoster. And you can see here in this study, and this study looked into the varicella infections. The same systematic reviews that looked into the varicella infection looked again into the effect of the vaccinations in general. And this systematic review included studies that came with the live attenuated virus. So this does not reflect the recombinant vaccination. But again, you still see that there was a very good seroconversion rate. We're talking about 77% to 94% in a very specific population that might not have a seroconversion. This is and looked into the safety, and again, because this was the live attenuated vaccine, again, it was shown to be safe in those patients. Very small number of patients had a transient rash, but none of those patients developed major complications. This study looked into the effectiveness of the herpes zoster vaccine in patients with end-stage kidney disease, again, compared with those who were vaccinated with those who were not vaccinated. And again, because of the time, I'm not going to go through a lot of the discussions on this paper, but you can see the Kaplan-Meier curve where the unvaccinated end-stage kidney disease patient had higher incidence of development of herpes zoster or shingles compared with those who were vaccinated. This is one of the landmark studies that evaluated the role of the recombinant vaccine in patients with renal transplant. This was a phase 3 randomized observer blind multi-center study that were conducted in 9 countries. Renal transplant patients randomized 1-to-1 to receive 2 doses of the recombinant vaccine. And the inclusions were adult patients of more than 18 years of age, 4 to 18 months after transplantation, and they have to have stable renal function and no graft rejection in the 3 months prior to the first dose of the vaccination. And how did they assess the immunogenicity? Through the humoral immunogenicity and also through the cell-mediated immunity. These were the other primary objectives. So mainly was the vaccine response rate to the measuring the humoral immunity. And again, as I mentioned, the cell-mediated immunity. The cell-mediated immunity, I just brought this graph just to show that the cell-mediated immunity was not checked in all patients, but there was a selected population that were actually selected to look into this, the cell-mediated immunity. But eventually, comparable numbers between the 2 groups were checked for humoral and as well as cell-mediated immunity. So you can see here the geometric mean of the increase in the IgE against the glycoprotein E. And you can see here clearly, this is the dark gray is the recombinant vaccine, and the lighter gray is the placebo. Looking into the humoral response in general without the geometric mean, again, you could see the remarkable or the significant or the robust effect of the recombinant vaccine compared with placebo. And this is the T-cell response, because T-cell response is actually the measure of the durability of the vaccine effectiveness. So it's very important to look at the cell-mediated immunity response with the vaccination, especially if we're talking about immunocompromised population. And I think COVID made every one of us an expert in the T-cell mediated immunity and response to the vaccination, because we really did not know how to measure the humoral response to COVID. But nonetheless, you can see here again that the recombinant vaccine had presented or resulted in a very robust cell-mediated response in those who were vaccinated. So the study concluded that the immunogenicity in chronically immunocompromised renal transplant patient was robust, and it did persist after up to 12 months post-vaccination. And I did not show this data, but there were no safety concerns arose during the study. Is there any studies that compared the 2 vaccinations in the general population head-to-head? I'm not aware of any. And of course, there was nothing to compare the 2 vaccinations in renal transplant patients. But whether we could use the live attenuated vaccine, there was some studies that actually reported that in patients who are on stable immunosuppressant medication, minimized immunosuppressant medication, so obviously they were not within the first few months after the organ transplant, and they looked into the herpes zoster occurrence, death, loss of allograft, loss of follow-up, or until 5 years of the vaccination. This study was from Korea, where they included 84 vaccinated compared with 340 unvaccinated individuals. And again, you could see that those patients were protected in all the outcomes that the study looked at. But and they actually mentioned that there was a significant protectiveness against the herpes zoster, and the risk ratio, as you can see here, decreased to around 18%. And again, this question will come up, whether we are going to, which one is better? Is it the recombinant vaccine compared with or the live attenuated vaccine? Again, as I mentioned, there was no studies that compared the two modalities head to head, but we could draw conclusions from studies like this one, where it looked into the vaccine effectiveness or the cell-mediated immunity, whether it wanes after the vaccination, and what is the median time of waning. And you could see here that up to the recombinant immune or the recombinant vaccination, the robust immune response, T-cell response, persisted for 9 years. And you could see in the table the effectiveness in the vaccine in terms of humoral immune response or seroconversion in the different age group, and also looking into the effect on the post-herpetic neuralgia, and how did that reduce the complication or reduce the incidence of the disease. What about different age or different immunocompromised population? You could see here in this table different immunocompromised population: hematopoietic stem cell transplant, patients undergoing chemotherapy for either solid or hematological malignancies, following organ transplantation, and HIV-infected patient. And you could see in the last two columns the immunogenicity of the vaccine, whether it's be humoral or CMI, cell-mediated immunity. You could see that the vaccine did actually resulted in a very good or robust immune response. At least we are talking about 50% and above. And this is in patients who are receiving chemotherapy, 50%. But if you're looking into renal transplant, we're talking about 80%, HIV patient 90%. And this is talking about cell-mediated immunity. Humoral immunity was more or less the same numbers. This was a study done by the CDC addressing, again, the same question, whether a live attenuated vaccine or recombinant vaccine is better in terms of protection. But here they did not only look into the cell-mediated immunity and humoral response, they looked into the functional effect of this humoral response. So on the left-hand side, the neutralization, so how well this antibody prevent the virus from attaching into the cells. And on the right-hand side is the ability, how well these antibodies attack the virus. In the left-hand side, you could see the previous or the upper part of the graph showing the no previous immunization, and then in the lower graph, previous immunization. And then you will see the names of the vaccine here. So ZVL is the live vaccine, and RSV is the recombinant vaccine. The red is the no protection, and then the green, how many folds of protection. And again, if you just look by the naked eye, you would see that the patient who received the recombinant vaccine were definitely had better functional immune response or humoral immune response, and here in this case, neutralization. And if you look here, the squares in pink are the recombinant vaccine, and the lavender or purple were the live attenuated vaccine. Again, this is in terms of ability or how strong will this antibody attack the virus. And you could see clearly that the recombinant vaccine had a more robust immune response or more functional humoral immune response. This is almost, I think this is the slide before last one. What about those who are seronegative transplant patients? Could we do a primary vaccination with the varicella vaccine? This is a group led by Dipali Kumar from Toronto, looked into this particular question. So those were solid organ transplant patients who were seronegative. I know the number is small, but I think it's just a proof of concept whether we could do that. Around 57 patients. Again, here I chose the graph that delineated the humoral immune response here, where you could see post-second dose, the strongest or the stronger immune response or humoral immune response. Same thing was seen with the cell-mediated immunity. So patient after one dose had definitely a better cell-mediated immunity, but after two doses, the cell-mediated immunity to varicella was higher. So I think this is also something very useful to know when we are dealing with our transplant population. As I promised, one slide about the treatment. Again, this is the 9-year-old review, but I think it explained the treatment in a very, very nice and simplified way. So we are talking about the immunocompromised patients on the right-hand side. So if your patient is immunocompromised, you assess the disease severity. And if the disease is severe, those patients need to be hospitalized, receive IV therapy. And if they do have neurological or ocular complication, then again, they will need to be on IV therapy. And we have to handle or anticipate the complications, especially post-hepatic neuralgia, and try to address that as early as possible, because it's very important for the patient's lifestyle and quality of life after the initial episode. So in conclusion, VZV can cause significant morbidity in individuals more than 50 and in immunocompromised population. And there is a clear evidence to show the impact of vaccination, whether it is live attenuated or recombinant, but more so with the recombinant, or reducing the incidence and complication of herpes zoster infection. As I mentioned, and I hope I made it clearer, that the recombinant vaccine had more robust immune response, humoral, cell-mediated immunity, and also functional humoral immune response. Vaccination is cost-effective, and the long-term data on the durability, especially in solid organ transplant, is still not available. But if we could do conclusion, I think we think that at least within the first 2 to 3 years after the vaccination, they are very well protected. But I think we are still waiting for the longer term duration or studies on the duration of the protection after vaccination in solid organ transplant. And with that, I conclude. Thank you very much.
يعطيك العافية. Excellent presentation, Dr. Reem. We're going to keep the questions to the end. I'm gonna, if you can stop sharing. So, thank you. So I'll just do a few slides. GSK asked me to do a few slides about incorporating Shingrix vaccine into our clinical practice. It's gonna take hopefully less than 10 minutes. So it's just we're gonna go over where Dr. Reem did an extensive work about explaining about the recombinant vaccination, but we'll just have a few technical slides. And at the end, we'll present our vaccine clinic experience at King Faisal. So as Dr. Reem mentioned, Shingrix vaccine or the recombinant Shingrix vaccine is a non-live vaccine, so it's not contraindicated in our immunocompromised patient or post-transplant patients. The unique part of Shingrix vaccine, it has this antigen glycoprotein E, which is the most abundant glycoprotein on the VZV surface. It is expressed during HSV activation on the skin and in the ganglia, and it does target, it is a target for humoral and cellular response. However, the unique part about Shingrix vaccine is actually the adjuvant system in it. It is in a carrier which is called like a ribosome, which contains two components, two unique combination of the QS21, which is a sapnin, purified natural sapnin, and the salmonella detoxified salmonella lipopolysaccharide. This combination of the salmonella lipopolysaccharide with the sapnin, it does help to trigger the immune system or the cellular and the humoral immune system against the glycoprotein E. And by this way, it gives you a stronger, broader immune response and a longer term immune response, as you saw from Dr. Reem review. It's very important to stress that the recombinant Shingrix vaccine or the inactive zoster vaccine is 2 doses. And whenever you give your patient your first dose, please try to schedule them for their second dose. And the second dose preferably should be within 2 to 6 months from the first dose, but specifically in immunocompromised patients and those who are post-transplant, it should be within 1 to 2 months. So this, what I do in my clinic is we give them the first dose and we book their appointment within 6 to 8 weeks from the first dose to make sure that they get their second dose. Why is it important? Your second dose is going to generate a 4-fold or more even increase in their cellular immune response versus only 1 dose. The Shingrix vaccine is safe to be given with any other vaccination. There is no concern for safety or even affecting the immunogenicity of other vaccination. It is kept refrigerated. It's given intramuscularly, and I think Dr. Reem went over the indication of the recombinant zoster vaccine. In our center at the Organ Transplant Center, we did create this project, and the whole idea came because we did note a high rate of HSV activation in non-vaccinated patients. So as of November of 2023, we established a vaccine clinic in our pre- and post-transplant population. And the aim was to optimize their overall vaccination, but specifically we had an interest to increase compliance to Shingrix immunization. We created a schedule that was distributed in our vaccine clinic that did follow the IDSA and the AST guidelines for the post-transplant population. And we did find, it was started in November 2023, and we compared our data to before and after the clinic was opened. We were able to increase the rate for Shingrix vaccination from 2% to around 73%. This is for the first dose, and increase the compliance to the second dose by 50%. We have a lot of work to do to increase awareness among our staff and our healthcare provider about importance of preventive medicine and importance of vaccination. But this is at least a start. There is a lot of lessons that I learned from this vaccine clinic, but the most important thing is to trying to take a patient as a whole and to avoid just focusing on a certain problem and forgetting the most important thing, which is preventive medicine. And many thanks to my team who helped to build this vaccine clinic and to do this great job. You can scan this QR code to access more helpful information about the Shingrix vaccine. And by this, I think we're done with the presentation. I'm going to go ahead and start with the questions. Give me a second. Let me see. So I'm going to start with a question to Dr. Reem before I read the questions. You touch on the durability of the vaccine post vaccination. This is what a dilemma that I face in my clinic is for post-transplant patient. When do you think is the best time? Do you think we should give them a booster dose after their second dose, like by 5 years, 10 years, or we don't have much information to guide our decision when it comes to booster vaccination of our patient?
Thank you very much, Dr. Reem, for the question. There were actually some recommendation about giving booster doses after 5 years, but not specifically in the solid organ transplant. And I'm not really sure if this is based on studies or based on observations from the previous vaccination that the vaccine effectiveness may wane. I think the challenge is, even if we test for the humoral immune response and we found that it has decreased, we really need the cellular mediated immune response to know whether those patients are still protected or not. And I think the study that was done by the CDC was a very neat study looking into, even if there is a humoral immune response, is that functional or not? So unless we have this advancement, I'm not really sure, even if we do the antibodies, are we going to know? And I think the best thing is to try and assess the net immune response in your patients, whether they had a breakthrough infection related to the varicella or had other infections that may suggest that their immune response has really weakened and they may benefit from another vaccination.
Great. I think I saw one of the questions and it was very interesting, which we face in our practice. If a patient has an active or activation of their HSV, they just had shingles, when do you recommend them to get the vaccine, if you recommend it anyway, from their active or acute infection?
Actually, there are some recommendations to vaccinate them even if they had shingles, because they may have a risk of recurrence of shingles. And I think the best time that at least the CDC has recommended is 2 months after the acute episode.
Then let's see what else. And there is a question about which patient should not receive the varicella vaccine. I'm not sure if they meant the varicella vaccine, the live attenuated, or our Shingrix vaccine. But probably I'm going to take it as the live attenuated, the varicella vaccine.
The general contraindication to live vaccine, immunocompromising condition that includes patients on active chemotherapy, solid organ transplant, higher dose of steroids. But again, I want to mention that the live attenuated varicella vaccine was studied on patients with leukemia receiving maintenance chemotherapy, and there was no major side effects that happened. Renal transplant patients, they're like the Korean study, they had administered live attenuated vaccine if their immunosuppressive medication has been stable after the first year of the vaccination, immunosuppressive medication has been decreased. And again, there was no major side effect. I'm not advocating giving life attenuated vaccine for patients with immunocompromising condition, but I'm saying that there has been some exceptions in the literature, and I think it should be weighed with the risk and benefit. And but I think now with the presence or the availability of the recombinant vaccine, I think we should be always in the safe side and use the recombinant vaccine.
A good question. Can Shingrix vaccine be given to pregnant women?
I'm not aware if there is any contraindication.
Another one about if it is contraindicated to be given with for someone with history of brain vasculitis. I'm not sure if
brain encephalitis.
Vasculitis. If the patient has brain vasculitis, is it recommended to give them VZV vaccine, or is it contraindicated? I'm not aware of any.
I think they fall, because vasculitis, they will be probably on steroid and other immunosuppressive medications, so they will fall into the immunocompromised patients. And I think those patients are definitely the highest risk for VZV reactivation. And I think the vaccine is definitely indicated in those patients. And again, we're talking about the recombinant vaccine.
And then there is a question about treatment, actually, of meningitis or encephalitis if occurred. What would you recommend?
With the VZV?
Maybe they meant, for VZV. Maybe they meant the choice of antiviral and the duration, probably.
The best antiviral for the herpes viruses, the VZV and HSV, is acyclovir, IV acyclovir. I mean, since this is the nephrology society, it's very important to mention that IV acyclovir is known to cause crystallization in the renal tubule and may produce renal dysfunction. So appropriate hydration is mandatory and is key to make sure that the medication is given safely. The duration of treatment usually between 2 to 3 weeks.
Right. Last question, I think, is if a child misses their first dose. I think she's asking what to do.
I think the Ministry of Health have their own catch-up vaccination. So I think the ministry do provide recommendations about if a child misses the vaccination, when to vaccinate, and how it should be done afterwards. So I will still recommend that to take the child again to daycare and ask about the catch-up vaccinations.
Right, I think we answered most of the questions. Thank you so much, Dr. Reem. I'll give it back to Prof. Mutwalli. But before that, there will be a survey sent to you through email. If you can please take a minute to fill the survey after the webinar ends. And back to you, Dr. Mutwalli. Thank you, Dr. Reem.
Thank you, Dr. Reem Al-Maghrabi, for this an excellent, very informative lectures. And I think I thank also my daughter Reem Al-Amir for her moderation. And I thank everybody present during this active, really an interesting webinars. And I thank the GCK for the support. And I don't have to thank more, our friend, the event group. But I really encourage everybody, please, when you receive the email for this survey, just fill it up. It'll take about less than a minute. It will be very informative for all of us. Thank you very much. Thank you, everybody. Thank you. Khalid, you want to say anything before at the end?
At all. So just as you mentioned, we'd like to thank GSK for their generous sponsorship for this education. Without their support, this platform wouldn't be happened. So we'll thank them. I would like to disclose that, and also I would like to thank the speakers and the moderator as well as the attendees. And I would like to disclose that today the concurrent attendees is 6,300, and we have almost 12,000 registered. So that put a lot of pressure on us, honestly, in choosing the topic and choosing the speaker and moderators. We know the full trust of all of you of attending this webinar, because the trust on our choosing the topics and choosing the speakers and moderators. See you next month. We have another webinar, inshallah, on June. And a poster will come to you, and it will hopefully will have all of you to attend it again. So once again, thank you everyone. Thank you, Dr. Reem Al-Maghrabi, and Dr. Reem Al-Amir See you next time وتصبحون على خير. مع السلامة.